So now we had seen about the general introduction to hematology. Let's move on to the erythroid series proper. So erythroid series, the initial precursor will be the pro-erythroblast. So this is the first cell which is being formed. So pro-erythroblast or a pro-normoblast. We use the term erythroblast or normoblast for erythroid series. Okay. So the pro-erythroblast is then going to form an early normoblast, then an intermediate normoblast, then a late normoblast, which will then form the reticulocyte and the mature RBCs. So this is the series of erythroid production. So the pro-erythroblast is the first cell, which is a blast. Okay. So this first cell is going to be also containing the hemoglobin. So the first cell to contain hemoglobin is the pro-erythroblast. Okay. So don't confuse. This hemoglobin is not visible under light microscopy. Only under electron microscopy you can see this hemoglobin. So if they, in general, they ask about which is the first cell to produce hemoglobin, it is pro-erythroblast. If they specifically ask which is the first cell in which you see the hemoglobin light microscopically, then you tell it as an intermediate normoblast. So first cell in which hemoglobin is seen under light microscopy is the intermediate normoblast. Under electron microscopy, it is the pro-erythroblast. So that is the first cell in which hemoglobin is being produced. So early normoblast is going to have a basophilic appearance. So the erythroblast, initially the cells pro-erythroblast and early normoblast are going to have a dark blue cytoplasm. Then when the hemoglobin starts to appear under light microscopy, so in intermediate normoblast, both blue color and this hemoglobin is going to be reddish pink, right? So pinkish blue is there. So it is going to give a polychromatophilic appearance. So both blue and pink is there. So it is going to give the polychromatophilic appearance. While in late normoblast, this is going to be replaced by a orthochromatic color. That is, it is going to appear only pink. Okay. So orthochromatic, it is a single color. So late normoblast is going to be orthochromatic. Then comes reticulocyte. So reticulocyte is going to be the first non-nucleated cell. So till late normoblast, you are going to have a nucleus. In fact, the nucleus of a pro-erythroblast is quite characteristic. We describe the chromatin of the pro-erythroblast as a sieve-like chromatin. So sieve is the one which we use for filtering the flour, right? So this sieve is going to have multiple holes. So like that, the pro-erythroblast nuclear chromatin is going to have multiple sieve-like chromatin. Okay. And the cytoplasm is going to be quite blue. So dark blue in color. So reticulocyte here, this is the first cell in which the nucleus had extruded. So nuclear extrusion is there. So reticulocyte is the first non-nucleated cell in the erythroid series, and also it is the first cell to appear in peripheral blood. Okay. So reticulocyte itself comes in peripheral blood, and this in the peripheral blood, this reticulocyte is going to stay for 1 to 2 days for maturation, and after that it is going to form the mature RBCs, right? So the mature RBC, what is the shape of the mature RBC? So both this reticulocyte and mature RBC are going to have no nucleus, right? So the shape of the mature RBC is biconcave. So biconcave, it is because there is going to be a central 1/3 pallor. So if this is the RBC, so in the center, 1/3 of it is going to be a pallor. So suppose this is the RBC here. This is all appearing dark pink, while the center is going to appear pale, and that is the pallor. So that is the normal shape because of the biconcavity. There is a central 1/3 pallor over here. And the size of the normal mature RBC is 7 to 8 micron, which is approximately the same size as that of a nucleus of a small lymphocyte. So in peripheral smear, whenever you have to compare the size of the RBC, whether it is small or large, you will have to compare it with the size of a normal nucleus of the small lymphocyte. Okay. So, and the lifespan of the RBC will be 120 days. So, this much we all know, right? So, a special mention about reticulocyte. So, reticulocyte is given the name reticulocyte because it is going to have a reticulum. It is going to have a meshwork of RNA. So, this RNA can either be seen as dots like this, either more than 2 dots must be present basically, 2 or more than 2. So, dot like thing or a reticular meshwork kind of thing. So, only when you see that kind of thing, you are going to call it as a reticulocyte. And this meshwork is not going to be seen under normal Romanowski stain. You will have to use the supravital stain to see this RNA meshwork, right? So, the normal reticulocyte percentage is going to be 0.5 to 2%. So, when in what conditions do we have increase in the reticulocyte percentage or the reticulocyte count? So, whenever the RBCs are being lost. So the bone marrow is going to try to compensate for the loss and start producing more and more erythroid cells. So our reticulocyte count will be increased in such conditions. So whenever there is RBC loss, like in a blood loss, so during a trauma or an accident, there is blood loss. So in that case, the RBCs, the bone marrow is going to be producing increased reticulocytes. Other than that, hemolytic anemia, that is peripheral increased destruction of RBCs is happening. So the bone marrow is going to try to compensate for that. So in hemolytic anemias as well, you are going to have the increased reticulocyte count. And then whenever you are having a nutritional deficiency, and then you are giving supplements for treating that. So in deficiency state, nutritional deficiency like iron deficiency or a folate or a vitamin B12 deficiency, where the actual nutrients needed for the RBC production is going to be deficient. So in that case, the reticulocyte count is going to be low. But when you are giving supplements for that, so the bone marrow will try to use the supplements and produce the RBC and RBCs to the normal extent. So there will be increased reticulocyte count with supplements. So in deficiency state of nutritional deficiency, you will have decreased reticulocyte count, while when you are providing supplements to compensate for that, there is going to be increased reticulocyte count. Then causes of decreased reticulocyte count. So whenever the bone marrow is not being able to cope up for the loss of RBCs, there is going to be decreased reticulocyte count. So when the bone marrow is already filled up with some material, that is as such the hematopoietic stem cells are going to be decreased, like a bone marrow infiltration, a lymphoma, a leukemia or a fibrosis or some other metastasis coming to the bone marrow. So in these conditions, the hematopoietic stem cells are going to go low. And then aplastic anemia. So the bone marrow stem cell itself is going to be defective, so it cannot form the hematopoietic cells. So in that case, as such, aplastic anemia and bone marrow failure, there is going to be decreased reticulocyte count. So chemotherapy, radiation, these again are going to cause the stem cell to be damaged. So in that case, again, there is bone marrow suppression. So there is no reticulocyte production. So for measuring the reticulocyte, normally what we do is we'll have to make the use a supravital stain and make a smear, and in that supravital stained smear we'll have to count the percentage of reticulocytes. So we'll count that with the based upon the number of reticulocytes per 100 RBCs. So we'll get a RBC percentage from that. So that RBC per reticulocyte percentage is not going to be the correct reticulocyte percentage, because the reticulocyte percentage is going to vary with the hematocrit of the patient. So the hematocrit is going to cause the variation in the reticulocyte. So for getting the correct reticulocyte count, you'll have to use a formula, that is the percentage of reticulocyte you have obtained by counting the cells, right? So that multiplied by the hematocrit of the patient divided by the hematocrit of normal. So normal hematocrit we consider it as 45, right? So 45 is going to be the normal PCV. So whatever is the hematocrit of the patient, so suppose the patient is anemic, his hematocrit is going to be low. So hematocrit divided of the patient divided by the normal hematocrit into the final reticulocyte percentage which we counted. So this is going to give the corrected reticulocyte percentage. Okay. So how do you count the absolute reticulocyte count? We can also give it as the percentage of RBCs, right? So you'll have to count the number of reticulocytes per RBC count. So you have to multiply the reticulocyte percentage with the RBC count, the total RBC count in millions. So that will give the absolute reticulocyte count. Then reticulocyte production index. So this is a very good marker actually. So this reticulocyte production index is again going to be based on the maturation time. So our reticulocytes usually come into the peripheral blood and stay there for 1 to 2 days for maturation into the mature RBCs, right? But whenever there is an loss in the RBCs, so the bone marrow is trying to compensate for the loss, so it is going to release the reticulocyte at a much earlier stage itself. So the reticulocytes is going to take much longer time in the peripheral blood to mature into a normal RBC. So that again is going to determine the proper reticulocyte production index. So for that we will have to again use a formula, which is a reticulocyte percentage divided by the maturation time. Okay, so the reticulocyte percentage divided by the maturation time in the peripheral blood. And this maturation time is again going to be determined by the hematocrit or the PCV. Okay. So suppose the PCV is going to be 40%, and then you can, if it is 40%, then the time taken for the reticulocytes to mature will be 1 day. So 30 to 40%, it is going to be 1.5 days. 20 to 30% it is going to be 2 days, and less than 20% it is going to take 2.5 days to mature. Okay. So this is the best indicator actually. So reticulocyte percentage divided by the maturation time will actually give a actual appearance of what is the proper reticulocyte. Okay. So on peripheral smear, how do these reticulocytes appear? So reticulocytes are going to appear as the polychromatophils. So these are the polychromatophils which we see in the peripheral smear. So they are having, this is the normal RBCs, right? They are having a pinkish appearance, while these cells are actually having no nucleus here. So if it is a nucleus is present with the polychromatophilic appearance, it will become an intermediate normoblast, right? Here there is no nucleus, but the cytoplasm is having a vague bluish pink kind of appearance. So that is why it is called as polychromatophils. So in peripheral smear, reticulocytes are nothing but the polychromatophils. But to actually count the reticulocytes, I told you will have to use the supravital stains, especially the new methylene blue stain. So under new methylene blue, if you see, the reticulocytes are going to appear like this. So in this, if you see, there is multiple dots, blue dots, right? So all of these blue color things are RBCs, and these dark blue dots are the RNA meshwork of the reticulocytes. So here again there is dots. So here if you see, it has become filamentous like this. More than dots, there is both filaments and the dots over here. So all of these are counted as reticulocytes. So you'll have to like this, you'll have to count reticulocytes for 100 RBCs and give the reticulocyte percentage. So next we'll see about the mature RBCs. So structure of mature RBC is important. So the RBC membrane is going to have the alpha and beta spectrum. So alpha and beta spectrum is going to form an intertwined membrane structure like this. So here is the head end of the alpha beta spectrum, and this is the tail end. So at the head end we have other proteins as well, which is the band 3 protein, band 4.2 and the ankyrin protein. This band 4.2 is also called as the paladin protein. And then at the tail end, you are going to have the glycophorin protein, band 4.1 and the actin filament. So this glycophorin was the CD71. So CD71, and this is the most abundant protein in the RBC membrane. So most abundant protein will be glycophorin, while this ankyrin which we see here at the head end, right? So this is the most commonly mutated protein in hereditary spherocytosis. In hereditary spherocytosis, it is a hemolytic anemia. So in that, the ankyrin protein is the one which is most commonly mutated. So this spectrum which we see here is going to be responsible for the biconcave shape of the RBC. So the shape of the RBC is going to be determined by the spectrum. So shape for spectrum, S for S. Most common mutation in HS is going to be ankyrin, and the most abundant protein in RBC membrane is the glycophorin or CD71, right? So let's see about the RBC indices now. So first thing will be the hematocrit, which is also called as the PCV, packed cell volume. So the packed cell volume of the RBCs is going to be 45%. So the next one will be the mean corpuscular volume, which is MCV. So MCV is nothing but the, as the name suggests, it is the mean volume of the RBCs. So it is packed cell volume divided by the total RBC count. And normal count is going to be 80 to 100 femtoliters. Then the mean corpuscular hemoglobin. So the number of hemoglobin upon the RBCs is going to give the mean corpuscular hemoglobin. So that is going to be 27 to 33 picogram. Then comes the mean corpuscular hemoglobin concentration. So for that you will have to divide the mean corpuscular hemoglobin with the mean corpuscular volume. So that will give the concentration of the hemoglobin in an RBC. So that is going to be hemoglobin divided by hematocrit. So if you apply this formula of MCH and MCV, it is going to be HB divided by RBC, PC divided by RBC. So RBC is going to get cancelled. So finally it is hemoglobin divided by PCV. So this is going to be, normal level is going to be 34 to 37 gram percentage. So this MCHC is going to be a much more better indicator as such. This MCHC is going to be increased in hereditary spherocytosis. So in hereditary spherocytosis, you are going to have spherocytes, so microspherocytes. If this is the normal size of the RBCs, the spherocytes are going to have a uniform color without the pallor here, and these spherocytes are much more smaller, microspherocytes. So these spherocytes, as the volume is going to be decreased here, the concentration of the hemoglobin is going to be increased. So MCHC is going to be increased in hereditary spherocytosis, and MCHC is going to be normal in megaloblastic anemia. In megaloblastic anemia, you are going to have elevated MCV and MCH. Both the size and the hemoglobin content is going to be increased. So proportionately, the size and hemoglobin is going to be increased. So when the volume is also increased and the hemoglobin is also increased, the hemoglobin concentration is going to remain the same. So it is going to remain normal in megaloblastic anemia. Then next comes RDW. RDW means red cell distribution width. So it is going to determine the normal size variation in the RBCs. So if there is going to be lots of variation in the size of RBCs, there is going to be increase in RDW. So the normal RDW is going to be 11.5 to 14. Okay. And this RDW will be elevated in conditions of iron deficiency anemia and also megaloblastic anemia. In fact, in iron deficiency anemia, it is going to be quite elevated. That is more than 17.5. If the RDW is there, it is kind of diagnostic for IDA along with the other features. Okay. So more than 17.5, it will be there in iron deficiency anemia. But if you see, it is going to be normal in thalassemia. So thalassemia is going to be a differential diagnosis for IDA. But if you check for the RDW, there is going to be much of anisopoikilocytosis in IDA as compared with that of a thalassemia. So what is anisocytosis? Anisocytosis, in the sense, it is size variation. There is going to be variation in the size of the RBCs, while poikilocytosis is variation in the shape of the RBCs. Okay. Size, as in the RBC size, normal size is going to be 7 to 8 micron. So it could be smaller in size or bigger in size. So that kind of variation in size, we call it as anisocytosis. Poikilocytosis, various shapes of the RBCs like teardrop cells, pencil cells, target cells. So all these are poikilocytes. So next we'll see about the ESR. So ESR is erythrocyte sedimentation rate. So the rate at which the RBCs are going to settle down, that we are going to measure in 1 hour with the help of certain methods. So that is what is called as ESR. So we can either use a Wintrobe's tube and we can measure it. So with the help of Wintrobe's tube, we can measure both hematocrit and ESR. While Westergren method is much more specific for ESR and it's also a better indicator. So Westergren, it is usually using a pipette. So here it is Wintrobe's, it is a tube, while in Westergren method it's going to be a tube. So both the ends are going to be open. So in this, the RBC settlement is going to be seen. So when the RBCs are going to settle, the RBCs will be settling down and the plasma will be accumulated up. So the part which is the plasma is going to be measured as the ESR, right? So ESR is going to be elevated in any inflammatory condition. Okay. So any chronic infections, tuberculosis, multiple myeloma, fibrinogen elevation. So all of this is going to result in elevated ESR. Okay, so fibrinogen is actually a clotting factor and it's also an acute phase protein. So it is a positive acute phase protein. So acute phase proteins are acute phase reactants basically. So these are going to be produced by the liver in response to any inflammation. So certain acute phase proteins will be produced as a positive one and certain will be produced as a negative acute phase reactants. So fibrinogen is also one such positive acute phase reactant. So it will be produced in higher amounts during inflammation. So when fibrinogen is going to be produced in higher amounts, it is going to result in elevated ESR. So that is why in chronic inflammation and it is going to be ESR is going to be elevated. So infections also is going to lead to lots of inflammation, right? And tuberculosis is also a chronic infective condition. While multiple myeloma, I mentioned, there is going to be rouleau formation. So these immunoglobulins are going to cause the abnormal stacking of RBCs like a coin stack, right? So when RBCs are going to be stacked easily, so RBCs can settle easily. So that will result in increased ESR. So multiple myeloma, again, increased ESR is going to be there. While in any other conditions wherein the RBC shape is going to be altered, so they will not be able to stack over each other. So one of the steps in our ESR will be the formation of rouleau. So whenever this rouleau formation is going to be affected, ESR is going to go down. So levels of ESR is going to go down. So any abnormal shape of RBC is going to cause decrease in the Rouleau formation. So in hereditary spherocytosis, you see lots of spherocytes. It's not normal. So it is forming a sphere actually. So RBCs are basically becoming spheres. So spheres cannot stack over one another like a coin, right? So their ESR is going to be decreased. Same for sickle cell anemia. So the sickling cells are going to become sickle.